Well, no mai hadamai, kia ora kato, and welcome to another In Discussion. Today I'm joined with Kirsty Connell, who is an occupational therapist, who's coming up to having 31 years of experience in the profession. And she's currently based in Taupo, and working for Pinnacle Midland Health Network, which ostensibly is a PHO. And she's well, I'll let Kirsty explain who she is and what she does. So welcome, Kirsty, to our conversation piece. And I wonder if you could just help us by telling you a little bit about your background, your career today, like a potted history of who Kirsty is, where she come from, and where you're at the moment.
Brilliant. Okay. So I originally trained at CIT Andrew, so some 31 years ago. And so most of my practice has been in the mental health arena. So I started originally at Lake Alice Hospital in the Manawatu region, and then worked in the mental health service in Manawatu for some time. Did an OE over in Kentucky, back into physical health for a wee bit, and then came back to Tauranga, where I worked in the mental health service there. So I guess the first 15 years or so was working in secondary services. And then I was in private practice for about 16 years, again working in mental health and doing some education and training work for organisations and supervision. So most of my background has been in mental health, and I've been in my current role as a health improvement practitioner in Taupo for just about 12 months.
All right. So tell me, how did you get into that role? Because until I saw your little piece, your little video about describing what it was you're doing, it just hadn't appeared on my radar that these health improvement practitioners existed. A bit of research I've done afterwards is to see that it's originally come from America. Am I right?
Yes, that's right. Yeah. Yep.
So do you want to tell us a little bit about what a health improvement practitioner does?
Certainly. So there was originally a pilot project started in 2017 up in Auckland. So the project is called Te Tumu Waiora. And so they started the project with a small group of practices in Auckland, and it was placing health improvement practitioners and health coaches within general practice. And the pilot project was really successful. So the health outcomes were really positive. And so since then, 20 odd more sites. So we've replaced now for just about 12 months. So we've got 5 health improvement practitioners here in Taupo and 3 health coaches.
So how do you get to be a health improvement practitioner?
Right. So it's a position for registered health professionals. And so generally the mixes that we're seeing in New Zealand is occupational therapists, psychologists and nurses tend to form the bulk of the health improvement practitioners. So there's a very specific training program because it's a really different role. It's quite different to the way we might traditionally practice in health. So ideally have experience, mental health experience ideally, although not absolutely necessary. There's a four-day intensive training program, which is classroom based, and then observed practice in the general practices, and then training and support and mentoring continues. So it's a really intensive training program, and it's based on, you're absolutely right, an American model that they've been using now for around 35 years or so, and seeing some incredible outcomes. So it's really nice to have that happening in New Zealand now.
All right. So who delivers the training program that you referred to?
So Te Po are currently coordinating that. So originally it was done through Procare, a PHO in Auckland, and now Te Po manages that training. So there's a group of, I think we've got about 40 health improvement practitioners in the country, and there are 9 what we call HIP trainers. So we use the term HIPs because it's much easier. You can imagine we cop a bit of flack for that acronym, but it is what it is. Yeah. And so I'm one of 9 trainers in New Zealand as well.
Okay. All right. So you trained as an occupational therapist, had experience in America, had private practice experience, predominantly around mental health arena, and now you're doing HIP. And how has your practice had to change to accommodate HIP?
It has. So I did some postgrad training. So I did my postgrad diploma in CBT, which was a nice, through Massey, which was a nice lead into this role. But it is a very different role, and for all of us that move into the role, we have to do things very differently. So we work it's a very busy environment. We can see up to 14 people a day, and general practices are really busy places. So we only have 30-minute appointments. So the challenge for many of us moving into HIP roles is, how do we do what we need to do in a very short amount of time and make it productive? But the model is so nicely structured that we're able to do that. So it's very much about high volume, so being able to see a lot of patients and see them very quickly, typically on the same day, so that it's a really nice accessible service, which is great.
So Pinnacle is a PHO which covers a certain area.
Yes.
And in that area, there are a number of HIPs practicing under that PHO. What's the picture across New Zealand for health improvement practitioners then? You know?
Yes, so at the moment, we're based in about 20 sites, or I think it's 25 sites around New Zealand. And the Ministry of Health have just released some more funding to increase this. So they're looking at developing 100 more sites over the next 18 months. So we're going to see a really big growth in both HIPs and health coaches in general practice, which is really promising. And it's a really exciting opportunity for occupational therapists, because as we've discovered, there are four OTs in New Zealand at the moment working in HIP roles, and it's a really nice fit. Right. Because it's a really functional and behavioural model, and it's about supporting people with health issues to live the best life they can.
Okay. And funding for your position comes directly from the ministry or through Pinnacle? How's the position?
So it's originally from the DHB and then through the PHO. Right. Yeah. So HIPs are typically employed by PHOs throughout New Zealand.
Okay. So it is very much a primary organisation and model that's being used and promoted.
That's right. Yeah.
You talked about seeing patients 17 in a day.
Up to 14. 17.
14.
Up to 14. Yeah.
In a day, so it's pretty concentrated work by the sounds of it. And my understanding is that people are seen straight away. That's one of the attractive parts of it for clients, I suppose. They're seen straight. Do they get straight to you, or are they referred through the GP or other practitioners?
So the idea is that we're really accessible. So we'll start off the day with half of our appointments booked, and we leave the other 50% open. So that means, practically speaking, it might be that a GP taps me on the shoulder and says, "Look, I'm concerned about Mrs. Smith. I've just seen her, or in fact, I've got her with me at the moment. I'm concerned that her mood is low. Are you able to see her now or very soon?" And so the idea with keeping appointments available is that we can see people on the same day. And so there's no formal referral process because we're very much part of the team. So I have an office next to the GPs. We chart directly into the notes, and we're there integrated as part of the team. So there are no barriers.
If I'm a client with a GP practice, how do I know I need to see a HIP? How do I get referred into you? Understand that your colleagues can shoulder tap you and say, "I need you to see Mrs. Smith straight away." But how does the general public know you exist?
So we've got pamphlets and we do advertising in the practices, but it's what we know in primary care is that that's often the first port of call for people who are having health challenges, whether they're mental or physical health. So, and I think, we're starting to talk about mental health more, so people are often going to their GPs and saying, "Look, I'm struggling with anxiety, or I'm not sleeping, or I'm having trouble with depression." And so GPs are the first port of call, so typically that's where people will go. So that's where we can be most useful because we're based in the practice.
So if you're seeing a client for the first time, you talked about a model that guides your practice. Can you say a little bit more about what that model looks like?
Mm. So the sessions are very structured, so that the model that we draw from is something called FACT. So it's focused acceptance and commitment therapy. So it's a third wave CBT model. So it's got its origins in CBT, but it was developed.
Cognitive behavioural therapy.
That's right. Yep.
Okay.
And but it was developed very specifically for brief intervention. So in 30 minutes, we always do an outcome measure. So we've got a questionnaire, we introduce ourselves, do the questionnaire, we do a short contextual interview, a short functional analysis to determine what the problem is for the person and what's most important to them on that day. Then we look at brief intervention and a plan. So the sessions are very structured, and that's where the model is really helpful, because the idea is that it's short, it's brief, but it's powerful intervention that's targeted to a person's needs. So we get good outcomes.
So when you see somebody, you go through the FACT approach, and then you actually do prescribe, tools or techniques that a person can actually go away and practice, much as CBT dictates something like that, but people have homework, if you like.
The idea is that essentially nobody leaves our room without a plan.
Right.
But the idea is that it's really simple. It might only be one or two things, because often I think what we do as health professionals is that we might come up with 6 or 7 different things that somebody might be working on, and it's just too much. So the beauty with brief intervention, it might be a very brief strategy. There's a clear plan that we collaborate with the person on, and then they rate how confident they are that they're going to be able to do that. So we make sure that it's a good fit for them, and it's a very behavioural approach. So it's about helping people move towards the life that they want for themselves.
I guess that's where the fit for occupational therapists really comes into its own, doesn't it? When we're talking about functional activity or mental health support in some way, that it is occupational focused. Do you find that?
It absolutely is. It's absolutely look at it through an occupational lens. It's about helping people live the life that they want to live, whatever that is, and driven by the patient.
Yeah.
So, and it's we don't tend to differentiate between mental and physical health, because you can't. If somebody's struggling with diabetes and low mood, you don't separate the two. You work with the person.
So I guess you have to have a pretty extensive toolkit and knowledge base to draw on, because people, don't just present with one condition, do they? I've got a low mood, and by the way, I'm asthmatic, I'm diabetic, and my mother's just died. It's an whole outpouring of issues, I suppose. Yeah.
Yeah, and what you're describing actually is often a typical consult, because we know that people that come into general practice to see their GPs are often presenting with 4 or 5 things. And of course, GPs have got 15 minutes and they don't have time to do it adequately. And but what we tend to do is work on the problem that's most important for the person at the time. And they can come back. So there's no charge for the service. Typically, we'll see people between 1 and 4 on 1 and 4 occasions, and there's no charge as well. So
what's your DNA rate like then?
Actually, quite low, because of the same day system. So
right.
And that's one of the beauties of the system. So you're capturing people right there, because often if you say, look, it'd be nice for you to perhaps chat to this person, or what about if I refer you to mental health services, the DNA rate is really high. Yeah. But in general practice, we're right there, we can see you now, and so we can capture things immediately, which is great.
So what's the connection between, if somebody goes to say health improvement practitioner and they've already got a community psychiatric nurse, and you're meeting with them, you're going through some of the things that they perhaps could try, what's the connection between what the community psychiatric nurse is doing and what you're doing?
Right. So it's very much needs based. So if people are struggling with severe or enduring mental health issues, then they may be supported by secondary care. As they recover or things start to go a little better, it may be more helpful for them to have a contact in primary care. But we rely very much on strong communication between services, so it's very much a stepped model, and people with different needs at different times will access the different steps of the model. So we're the first step in primary care. We have psychology or talking therapies at step 2, and step 3 are secondary care mental health services.
Do you have shared notes, electronic shared notes?
Yes, so we chart directly into the GP or the medical centre records.
And those in the extended primary care team out in the community, do they have access as well?
They do, yes.
That's really,
yeah.
And that's Pinnacle's work, is it? That's part of Pinnacle's sort of
Yes.
infrastructure, that they have those combined notes, multidisciplinary notes.
That's right, yeah. So we use a patient management system called Indisi, which is a fairly well-known one in New Zealand. And so I work as part of an extended care team that sit next to the general practice, so dietitians, social workers, exercise consultants, clinical pharmacists, child health nurses. So we work within that team, but the HIPs are based directly in the general practice.
Right, okay. You talked about evidence, and whatever we do in health, we actually have to have evidence that it's working, and it sounds like it is. So can you tell me a little bit more about what you're seeing that suggests this is great, this is working?
Right. So from the American work, there's a plethora of evidence. What we see, and I guess this is me talking anecdotally over the past 12 months or so. So we see one of the principles is skills before pills. So a GP, for example, will, instead of immediately prescribing sleep medication or antidepressant medication, will refer to the HIP. So we're seeing a reduction in the rate of prescribing medication for things like sleep and depression and anxiety. We're seeing people better able to manage long-term conditions. So numbers like a person with diabetes, their HbA1c, blood sugar numbers are dropping. So we've got evidence to support that. So we're seeing extended consults, which is where a GP will book a double session with a patient. The rates of those are coming down as well. So GPs are not having to spend the time on some of those longer term or more challenging behavioural issues, which we can help support with. So we're seeing some quite tangible gains, which is brilliant.
Yeah, and is that collected sort of across the network, across Pinnacle or other health improvement practitioners, or you talked about it being anecdotal, and there's no denying that that's important. But I'm just thinking about a wider collection of evidence to support the funding that needs to.
Yes, so we complete stats after every consult, and those stats go through to the ministry. And so, just thinking of the numbers, I think in the first 7 months here in Taupo, I think we had over 1,000 consults. So we're certainly in terms of the numbers, and we're just starting to really gather those stats now and look at specific outcomes.
Right.
With people.
We've been through, we're still in a sort of pandemic. Things are good at the moment. We're at level 2. Have you seen cases coming forward, mental health cases coming forward, related to what's happened in New Zealand and around the world?
Yes, very much. So, and whether it's an exacerbation of a mental health challenge that somebody's already got, so if they're struggling with depression or anxiety or other mental health issues, we've certainly seen that exacerbated with some people because of COVID and lockdown. But we've also seen people experiencing COVID anxiety, which has, very, very much been a thing. Isolation, lots of those stresses, job losses, uncertainty, lots of things happening. But so we went quite quickly to a virtual model, using both, platforms like Zoom and DoxyMe, and doing telephone consults as well.
Right.
So,
and do you think that'll, as that's take on, and that'll happen more in the future, that we'll do things by virtual telehealth mechanisms?
Yes, I think it will. And our aim actually is to, if we can, to look at 70% in-person consults and retain 30% virtual, roughly. Because, you know, for so many people, it actually works better. You know, for people who live rurally, or it's hard to get into practice, or they, you know, struggle to put petrol in the car to get into the practice. So often people won't go to the GP because they can't afford it. It means that we can still provide the service. And the outcomes don't tend to be too different when you look at satisfaction ratings. People are still happy and still get outcomes from both phone and video consults.
This is an individual activity, I guess, with you and the client. Is there any work that's been done for health improvement practitioners to work with groups?
Yes.
And whether that's something that might take off in the future, already exists?
It's happening already, yeah. So I guess there are, to explain it in context, we have a trident approach. So if you think about 3 prongs, the first prong is direct patient work, so the intervention with patients. The second prong, if you like, is educating and supporting the practice team, so training them in delivering behavioural interventions so they can use some of those as well, so upskilling the team. And the third level is looking at population health. And so that's where we're definitely looking at things like groups, specific pathways, so working with people with long-term conditions like diabetes or chronic respiratory conditions. And so groups, shared medical appointments, education sessions, webinars for patients. And so the idea, it's a really innovative model, and it's in marae clinics as well. So how can we get people's needs met that might not ordinarily get access to services?
Gosh, that's really interesting. Sounds very exciting. How do people get a job as a health improvement practitioner then?
I think it's probably keeping an eye on Seek at the moment, to be honest. No, but there are going to be, there's 100 sites being developed around the country. And they're all fairly well advertised. So the PHOs are the ones that are employing those. And I'd love to see more occupational therapists in this role, because it's such a good fit. So it would be wonderful to see a good third of those 100 sites employing occupational therapists, you know, alongside psychologists and nurses who are also a really good fit.
Yeah, I mean, as you probably know, we have one scope of practice for occupational therapy. Do you think that's okay for people that work in the way that you do, or do you think we should develop specialist scopes of practice? That's probably a tough question.
It is.
Interested in your thoughts.
It's not something that I've really thought about, but I wonder if it might be the way of the future, because there are so many areas that we're developing in, and I think as occupational therapists, because we're trained in both physical and mental health and can work in so many different areas, I think it's really worth considering.
Okay, Kirsty, thank you very much for your time. It's been really interesting. I didn't know anything about health improvement practitioners until I saw your clip telling us what it is you do. But thank you very much for your time. Good luck with all that's happening in your area, and I hope that we see more occupational therapists working in the role of a health improvement practitioner. Thank you very much. Thank you very much.
It's a pleasure.
Thank you.
Thanks, Andrew. Thank you. Ka kite.
Thank you.